Morning report. It's a delight to have you here. Kirtan was just pointing out that this is the first time that we're starting at a relatively unusual time at 10:30 Pacific and almost midnight in India. And we're delighted for those of you who are able to accommodate that quirky time and join us today. My other half, unfortunately, is not here. Charmaine is on service, and it's been busy everywhere, I think, but especially on her team, so she won't be able to make it today. And I think the key question is, who's going to help fill that massive void? No pressure at all, but love for a case presenter and a discussant. Ideally, we get two discussants to learn and grow together, but if we get one, that's okay. We can still learn and grow together. So I'll call out to somebody who would like to present a case, and for folks who would like to jump into the lukewarm seat and discuss. Hi, Laura. Hi, Promise. Good morning. Good afternoon. I love it. You know, people who watch this at the end of the day are like, huh, this is a lot of silence. But it's only been about 20 seconds. It's amazing how long it feels. Mario, hello. Do you want to unmute yourself and remind the VMR crowd of where you're calling from and what you enjoy?
Yes. Hi. Can you hear me?
Yes, loud and clear, my friend.
Yeah. My name is Mario. I'm calling from Lima, Peru. I've discussed a couple of times. Always excited to join. A lot of learning every time. So
wonderful, wonderful. Promise. Hello. Please say hi.
Hi everyone, my name is Promise. I'm a second-year medical student in the US. I joined VMR in May, and then I discussed a couple of times. But I think if anyone is on the fence, please take my spot. It's really great.
Oh, you're too kind, Promise. You're way, way too kind. You know, I don't know if it's me, but it's a little hard to hear your voice. I don't know if it's the headphone or something. But yeah, we can hear you. It's just very soft, which is totally okay. We can make do. But I want people who will listen to this afterwards to be able to hear your voice loud and clear. All right, we got two people in the lukewarm seat, but we need somebody else to start the show. Does anyone have a case to present today?
Is this better by any chance?
Oh my God, it's awesome. Thank you so much. That's perfect.
Okay.
Oh, it looks like Kiara might have a case for us. Okay, perfect. Kiara, do you want to, I don't know if I misinterpreted that.
It's a human DX case, maybe.
Yeah, all right, perfect. I don't know, Vale just said the same thing in the chat, so I don't know how you want to divide and conquer that, but that sounds wonderful.
Maybe I can present as I am scribing.
Okay, perfect.
But maybe it's a simple case. I don't know what it is.
Oh. The goal is to make everything simple.
So something I can do is like send Gabriel this case so he can present it.
Yeah, whatever.
Okay, so Gabriel is the case presenter today.
Incredible. Do you happen to know, Kiara, what the chief complaint is? So while you're sending it,
yes,
you can say the chief complaint.
Of course. Yes, we can start with the chief complaint. This is dyspnea.
Dyspnea. Okay, wonderful. Promise, what are you thinking when you hear, you know, it's not uncommon in the world of clinical medicine to just have that. For example, where I work, there's a board that has the patient's name and their chief complaint. So when you hear dyspnea, what are you inclined to think of?
I think that when I think about like shortness of breath, the first thing I would associate with is like heart or lung problems.
Beautiful.
And then I wanted to ask a lot of questions about like when did it start?
Mhm.
And then kind of thinking like, is it an infection or is it like other manifestation of that? Like, is it the organ problem? And then I wanted to ask essentially, like if they have like family history with any heart disease or lung disease, and then just taking like a really detailed history to see like where it started and like their past medical history. And also like when they have shortness of breath, I wanted to know for their exertion level, like is it like if they're just, do they have that when they are like when they're exercising, or do they experience that like even just normal like daily activities? And then definitely for vitals, I would want to look at their oxygen saturation rate. Yeah, that's all I can think of right now.
I think that's superb. I think you took us very far and you told us the landscape of dyspnea prioritizes cardiac and lung problems, and gave us a few examples of those. But you also told us something really important, which I hope to emphasize, which is you said the first key question I would ask is, when did this start? And I think that if you just play a game of saying, I'm a 31-year-old man presenting with shortness of breath for the last 2 years, versus I'm a 31-year-old man who presents with shortness of breath for the last 2 hours. The differential diagnosis has changed dramatically with the tweaking of the time course. And I love that while it is always going to be heart or lungs as the primary causes of shortness of breath, what the time course is influences which cardiac and which pulmonary diseases to prioritize. Interstitial lung disease is not going to present with shortness of breath over 30 minutes unless there's been a complication. Flash pulmonary edema is not going to present as a cause of shortness of breath for the last 2 years, right? So getting the lay of the land is very, very important. And the lay of the land is what is happening and over what period of time. That's the first key question to establish in any chief concern, which is what we've talked about as the space, meaning the concern, and the time continuum. Extending our dear friend Aaron's analogy of E equals MC squared. It's true for any complaint. Mario, this is a little bit of a harder question, and I only pose it to you because I've been privy to many of your brilliant discussions. And I will ask us to come up with a list of, pretend that you're in real life and you are triaging, meaning that your job is to make as much progress as you possibly can and every second counts. So Promise said the first key question is time course. What else do you think in terms of the history helps you make the biggest progress in terms of what's going on with just asking about nothing but the HPI? So ask yourself, how can I be as quick as possible? And what high yield questions do you think about in the HPI for a patient with shortness of breath?
Well, I think I would ask for associated symptoms. For example, is this patient also have chest pain? Does this patient also have abdominal distension? If this patient have any stigmata of maybe cirrhosis, or I would be looking for different points that could point me towards a type of diagnosis. And I also would explore possible risk factors. For example, does the patient have hyperlipidemia, hypertension, smoking history, and stuff like that.
Beautiful.
Prioritizing the acute diseases that can cause dyspnea.
Amazing. All right, I love that. Now I'm going to ask you to tell me which one you think which associated symptom helps you be more confident about what's going on. So if a patient says I'm short of breath and I have orthopnea versus I'm shortness of breath, I have shortness of breath, and I have abdominal distension, which one are you more confident about in terms of taking the lead?
Well, I think orthopnea is like a semantic qualifier to the dyspnea, and I think it's a lot more specific for a couple of differentials. And abdominal distension could be water, solid, or gas, and it can associate with dyspnea for causing diaphragmatic immobility. But I think the orthopnea is a lot more specific towards certain diagnoses.
I couldn't agree more. I would say that after having thought about this for probably too long, I think the three most specific questions that help you make tremendous progress are any signs of volume overload, which can include orthopnea or bilateral lower extremity edema. 1. 2, a fever. You just think about how many patients with cardiac diseases, acute coronary syndrome, heart failure, arrhythmia, very few cardiac causes result in fever. A fever in a patient with shortness of breath prioritizes the lungs and changes the pyramid into basically lungs plus other. Now, don't get me wrong, endocarditis, pericarditis, myocarditis, sure, but how common are those compared to a pneumonia or a viral respiratory tract infection or an empyema? Much less common. And the final symptom, these are just like based on my job, which is triaging 50, 60 patients a day. The most helpful thing I think outside those two is actually signs of presyncope. So dizziness or lightheadedness. Dizziness or lightheadedness is a perfusion problem. When patients, they're like, I'm short of breath, but when I get up, I feel lightheaded. That doesn't happen in COPD, it doesn't happen in pneumonia unless they're dehydrated. But it really suggests a vascular problem of blood flow, which prioritizes the heart. That last one is not as good as the other two. So when I walk into a room and I'm having to move things quickly, unfortunately, I abandoned the notion of open-ended questions in the triage room, which is something we should all do when you're not triaging. But triaging, you don't have time. And so I walk in the room, I ask politely, of course, but quickly, time course, volume overload, presyncope, and fever. And then I take a minute or two to let the patient color the rest of the story. But there's virtually nothing that they can say that is more helpful than me knowing these four things from the beginning. And then I seed control and keep it open for a minute or two. And then we triage them appropriately and somebody else talks to them with more clarity. So I say this because we in medicine have spent a lot of time trying to understand the performance characteristics of physical exam findings, the performance characteristics of labs and imaging. And I think a new frontier for all of us in clinical reasoning is what are the performance characteristics of history? And often we don't study that as rigorously. So hopefully somebody will start doing that soon. But in my experience, I think these are the three questions that are very helpful in shortness of breath. And so I'm excited for us to learn them and go from there. I'll open it back to Promise and then Mario. Any other things that you'd want to add before we move on? All right.
Oh, I don't.
All right, Mario shaking his head. All right, back to you, Gabrielle.
Oh, guys, I'm so excited for this case. It's a very nice one. So for the history of present illness, the patient has a worsening shortness of breath, a low-grade fevers for 2 weeks. With lower extremity edema and orthopnea. He had never had these signs and symptoms before. And no chest pain. For the past medical history, he had a metastatic melanoma to the lungs. And he received 4 cycles of immunotherapy. Last cycle was 2 weeks ago. He never smoked, works as a financial analyst, no recent travels or illness. And no sick contacts at home or at work. He lives with his wife. And let me stop there. Or maybe I can give you the physical exam as you guys wish.
Gabrielle, I think there's so much here to digest. So I'd love to learn from Promise and Mario. And yeah, Promise, maybe you can focus on the HPI. We get a lot of helpful information in the medical history. I'm curious how you would incorporate the HPI section into the chief concern.
Yeah, I think this is a lot of information and it's very interesting. I think like the fever definitely popped up to mind, especially after you talked about how with fever you can pretty much think like stay away from the heart and think more to the lungs. So, and then also with 2 weeks, I think 2 weeks is a pretty short time frame. So and then there's no prior history of this kind of illness too. So I'm thinking more maybe like an infection. It seems like a pretty sudden onset to me. And then I thought the lower extremity edema and yeah, I don't know if I'm pronouncing it right, but I thought that's really interesting. And I wonder if this patient may be obese by any chance, like because I think COPD could have that. And then with, I don't know much about it, but I think for patients who have orthonia, like they can, like it's kind of related to lower extremity edema. So I just thought that's really interesting.
I love that. I loved how you separated it into two compartments. We're saying that edema and the orthopnea are related, and you analyze them together and you analyze the fever separately. And I love that pairing. I think it's a very fair assumption to say the orthopnea and the edema are related and the fever is separate. And this is clinical medicine for you, which I know I'm going to delve into in the near future. If we take our discussion before and we keep it simple, we say fever equals lung, orthopnea equals heart. Here you got both. So what do you do? The first lesson, I think, is to remember in medicine that you don't have to have only one diagnosis. You could have a pneumonia in the lungs triggering decompensation of previously subclinical heart failure, which is a very common condition. So this patient may have had compensated heart failure and then developed pneumonia, and here they are. But often it's helpful to assume that there's one common diagnosis for the sake of simplicity and cost effectiveness of your workup. So what is stronger here? Which weighs more? Does orthopnea equal heart weigh more, or does fever equals lungs weigh more? And I will tell you that orthopnea is much more specific to cardiac disease than fever representing a pulmonary process. Because, as we talked about, fever from the heart could be any itis, pericarditis, myocarditis, endocarditis, or very rarely a coronary vasculitis. So I think that's, if you're going between the two, you're probably prioritizing heart because orthopnea has a high specificity. Mario, what do you think of that conversation? And I'm curious how you incorporate the rest of the data here.
Yes, I would start with the time course because I agree it's fairly acute, but I would characterize it as subacute. And important here is that 2 weeks is just, I think it's too long for a community acquired pneumonia. And I think that's something important to keep in mind in a patient coming with shortness of breath and fever. Secondly, the lower extremity edema and the orthopnea make me think and especially in a patient with dyspnea, makes me think localizes me to the right side, to the right heart, to the right side of the heart. And I'm not sure if there's an infectious or inflammatory process that could cause right heart failure from a pulmonary cause, meaning causing cor pulmonale or pulmonary hypertension in just 2 weeks. I think I can't come up with a diagnosis. I'm pretty sure there is, but I think it would be not that common as a cardiac process in this case. And when I think on the heart in a patient with fever and shortness of breath, I will be prioritizing an inflammatory process, either in the endocardium as endocarditis, in the myocardium as myocarditis, or the pericardium as pericarditis. And I think the past medical history here is pretty rich, because metastatic melanoma can cause pericardial metastasis and can cause pericarditis. I would expect chest pain, and this patient doesn't have that. But the patient also has received immunotherapy. So I'm not sure what type of immunotherapy he has received, but I would associate immunotherapy more with a myocarditis type of picture, especially with a patient having his last cycle 2 weeks ago, and symptoms presented 2 weeks ago also. So I think that's what that's what I'm thinking right now.
Brilliant. I have nothing to add to that reflection. Promise, have you learned about immunotherapy yet in medical school?
No, I just started my second year.
That's why I asked. I think immunotherapy, it's not something I learned about in medical school. And the reason is it's very new. And immunotherapy is a fascinating therapy style where the goal is to augment, usually chemotherapy, the goal is to can't kill all cancer cells. And as a byproduct of killing all cancer cells, you kill all cells, period, including immune cells. And as a result, when you give patients chemotherapy, they're at higher risk of infections. Immunotherapy is the exact opposite. Immunotherapy prolongs the action of certain cells, immune cells, so they go and kill the cancer. It's crazy. It's basically arming your immune cells with the ammunition to destroy cancer cells. And the consequences of that, the side effects of that, are exact opposite. Instead of more infections from chemotherapy, which kills the immune system, here, immunotherapy augments the immune system, and as a result, many autoimmune diseases develop as a consequence. And these autoimmune diseases go from head to toe, from pituitary dysfunction to thyroid dysfunction to heart dysfunction, lung dysfunction, liver dysfunction. Take any organ and add this an itis to it, basically. And Mario here is emphasizing that, pericarditis, myocarditis, and endocarditis, of all the cardiac itises, myocarditis is the most common described complication here. I love, though, that Hans and then Mario emphasized that cancer without immunotherapy can go to the pericardium. The most common site of metastatic disease to the heart is the pericardium. And so that we'll have to think about for sure. At the same time, you might want to zoom out and say, okay, this is a patient with cancer who has shortness of breath. What could be happening to them? Oops, one sec. Thought I had it ready. And one sec. This is on the website, but you have to step back for a moment and say, you know what? Promise told us that there's the pyramid, lung causes, cardiac causes, and at the top of the pyramid are other causes. Promise used the orthopnea to zero in on the heart, and Mario reminded us that a malignant pericardial effusion can do it. In the myocardium, treatment is the more likely cause, causing from chemo, radiation, or immunotherapy. Remember that patients with cancer don't eat very much and can get beriberi, thiamine deficiency, and very rarely, instead of infiltrating the pericardium, the cancer can infiltrate the myocardium. This is a very rare entity that I'll skip over now, but let's also remember that the orthopnea and the edema may be a consequence of unrelated, age-related heart failure. And the patient may have pneumonia, may have extensive pulmonary disease burden, or may have immunotherapy or toxicity in the lungs. So I think the next key question is, let's localize the lesion to heart or lung versus heart and lung, and apply Promise's approach to the cardiac and Mario's layering on of the cancer, and hopefully we'll be able to make a lot of progress. Alrighty, Gabrielle, back to you.
Awesome discussion, guys. So for the physical exam, we have the vitals a temperature of 38 degrees Celsius, a heart rate of 110 beats per minute, a blood pressure of 160, and a respiratory rate of 18. And saturation of oxygen was 90% on room air. In the physical exam, the cardiopulmonary exam showed bilateral basilar rails, a normal S1 and S2, with a S3 gallop, and an elevated jugular venous pressure. There was a 1+ beating edema around the ankles and with warm extremities. The EKG showed just sinus tachycardia without any ischemic findings, such as ST elevation, pathological key waves, hyperacute T waves, just sinus tachycardia. And for the labs, we have a erythrocyte sedimentation rate of 40, which is elevated. C-reactive protein of 20, also elevated. The white blood cells was 15,000, which was elevated. Troponin I was 5, also elevated. And the basic metabolic panel was all normal. The AST was 70, which was elevated, and the ALT was 65, also elevated. And that's it for now. For the blood pressure, it was 100, the systolic, and 60, the diastolic.
Rebecca, thank you so much for presenting this case so clearly, despite it not even being something that you have put together. Thank you. So Promise, if you were to focus on the exam, what jumps out to you from the exam? I know you maybe not examined too many people in the end of first year of medical school, if any. I didn't actually examine anyone until the middle of second year. But you've been here a lot, and I don't know if you picked up anything from your instinct or anything at all. Where are you at with this exam?
Yeah, I have not seen any patient because of COVID. But from this exam, well, the patient is having a fever and he's tachycardic. His blood pressure is definitely high. And then his oxygen is pretty much like borderline hypoxemia. Or that his physical exam seems pretty aligned with his presentation. And then I forgot what the S3 heart sound means, but then looking at his white blood cell count, I think that's definitely elevated. And it's funny because yesterday I learned about ESR and CRP, and I think those means that your immune system is pretty active and there's some kind of like inflammation going on. It's usually more of acute inflammation. I forgot what the troponin means, but then seeing that the liver enzymes are elevated, I feel like that's also something that brings my attention to as well. I thought the edema around the ankles, I don't know if there's like a difference between like maybe the more like in the leg and then the ankle and the foot kind of edema, but maybe that could give some clues, and then it's 1+. So it's not as bad, like it's not that bad yet. That's that's all I have right now.
Beautiful. I agree with you. I think the amount of problems here, S3 gallop crackles, seems to be more than the problems in the legs. And that might be a sign of what Mario was talking about, which is the time course. When heart failure develops more quickly, it tends to leave the fluid much more here than it does in the lower extremities. The best example of that is what we call flash pulmonary edema, where the heart failure develops over seconds to minutes, in which case most of the fluid ends up in the lungs. So while not fully precise, the relative proportion of the fluid being in the lungs and the heart instead of the legs tells you that the system has not had time to adapt to this retention of fluid. So let me tell you about S3. So there are many different ways that the heart can be abnormal, including murmurs and gallops. And murmurs are essentially, I don't know what the correct term is, but they're essentially sounds between S1 and S2 that are more prolonged. And S1 and S2 are basically instantaneous sounds that make a blip over the stethoscope. And an S3 is a sound that occurs right after S2, which is the closure of the aortic valve, that symbolizes ventricular, either right or left-sided stretch. And it is the most specific sign of heart failure, period. Unfortunately, it's very hard to hear. And so it is a function of the skill of the examiner, and also very rare because it's so specific, it makes it very insensitive. All right, I'm going to ask the chat a challenge question for everybody. How do you know that this patient does not have a pericardial effusion? Okay. Mario walked in and said, hey, we have to worry about a pericardial effusion in a patient with cancer who develops heart failure. But I'll tell you, this exam tells you the patient does not have a pericardial effusion. And we'll talk about that. But I'll pass the mic to Mario to reflect on the additional data. So anything that he would comment on the exam to add on, and then in the labs as well.
Yes, I think we're localizing right now to the heart, and I think this is a pretty clear picture of a right side heart failure. And I think the physical exam here is key, because if we're thinking about inflammation plus heart, first we could start by in the endocardium as an infectious endocarditis or a different type of endocarditis, but we don't have a murmur here. That doesn't mean there's no endocarditis, but I think it lowers the probability of that happening. If I try to answer your question, I think the fact that we can hear the sounds lowers the probability of there being a pericardial effusion. And usually, not always, but there's a very good correlation between effusion and pericarditis. Not all pericarditis has effusion and vice versa, but they usually go together. And so the last standing out of this very superficial analysis would be myocarditis. If we go to the EKG, I think the typical findings of I'm not sure if we would see if this was endocarditis, if there would be an EKG manifestation other than a AV block secondary to a perivalvular abscess. That's not the case here. Pericarditis, we usually find diffuse ST elevations with PR depressions in stage 1, but we know that there's a evolution, and this is 2 weeks in the disease, so we could be on a stage 2 of the EKG evolution of the pericarditis, and usually that's normal. And then you have the T-wave inversion, so we could be just at the point where we don't see it. But I think that added to CRP and ESR elevations and mild AST and ALT elevations, that doesn't mean that there's a liver involvement. Just it could because we know that these enzymes, although more specific to the liver, can be present on other cells. So this all could just be part of a picture of a myocardial inflammatory process. I'm not sure if I could do more progress thinking about the etiology. I think myocarditis is a really, it just has too, especially in the infectious category, it's very broad. I would try to keep in mind that although we have a very strong past medical history to work on, to layer on that on the differential, I would keep in mind other diseases that could cause this. For example, some type of viral illness that's the most common, or autoimmune diseases, or disseminated bacterial infections or funguses that I don't think that's going on, but I think it's important to keep that present.
Brilliant, absolutely brilliant. I love that you walked us through the imperfect performances of an EKG and pericarditis, and you're really landing on the possibility of myocardial disease, and still within there keeping a broad idea, making sure that you're not anchoring on immunotherapy, but thinking about viral infections and things of that nature. The chat crushed it. The combination of Hans and Colleen are really making excellent points about how a pericardial disease process is much less likely. I think the first is, even before you hear that S3 is, this is a patient who's presenting with left and right heart failure, and pericardial disease tends to be much more right greater than left. Why? If you think about this being the heart, the pressure from the pericardium is so high that there's impaired filling of the right ventricle and the right atrium. And so, because of the impaired filling of the right ventricle and right atrium, there's less blood that goes to the left ventricle and left atrium. Because of the relatively low amount of blood making it to the left ventricle and the left atrium, there's less blood that backs up into the lungs. Does that make sense? So you're one red blood cell, and now you've just made it into the right atrium. And if you have LV dysfunction, you make it jump through the RA, RV, into the lungs, into the LA, into the LV just fine, and boom, you hit a roadblock. So you back up into the lungs. The pericardium causes elevation in all compartments beginning in the right atrium. And so there's a traffic jam that begins in the right atrium. And so, of course, when there's a traffic jam, that traffic jam extends all the way into the left ventricle, because the pericardium has pressures on the left ventricle too. But there's relative sparing of the lungs because the backup is more diffuse and begins in the right atrium. The other definitive thing is, and then I'll lead to the final point, is S3 is a sign of left ventricular stretch. Okay, when you hear an S3, that means the LV is dilated. And in the pericardial disease, the LV is compressed. So you won't hear an S3. So in order of specificity, you all nailed it. The most helpful thing is the presence of an S3. The second most helpful thing is the fact that you don't hear a friction rub or reduced heart sounds. And another layer is that it's actually here more left than right heart failure, as Promise pointed out very early on. Now, why do I say this? I say this because you have to then learn what the BNP is in heart failure. Just like an S3, the brain natriuretic peptide, BNP, is a function of stretch of the atria. And so a BNP is expected to be low in pericardial causes of heart failure. Now, why do I teach you this? I teach you this because we often rely on the BNP because our exam is not perfect. And we use the BNP to be like, you know what, maybe some volume overload. And if the BNP is low, you're like, it's not volume overload. That's not true. There are many causes of a low BNP heart failure. Obesity is the most common, and the pericardial disease is the most morbid. Okay? So where are we at now? I think Mario is really focusing on myocarditis, and for very good reason. And I would love for the chat to reflect on how you all think of myocarditis. But maybe we can open it back to Mario and Promise. This is an area that all of us are probably less knowledgeable than we would want to be, myself included. Because right now I can't tell you that I have an organized way of thinking myocarditis. So let's just build our knowledge collectively and lean on the chat. So I'll open it to you both. Like when you hear myocarditis, just start thinking of what it could be, and then maybe we can try to organize it together in real time.
Maybe I can go first. I used to have a a differential. I think I lost it, but I think I would start by infectious and non-infectious causes. Infectious prioritizing viral diseases, like I think echovirus is the most common. Sorry, I think it's Coxsackie virus. And in non-infectious causes, I think systemic autoimmune diseases, I think especially some type of vasculitis. I'm not sure if large vessel vasculitis can give you myocarditis. I'm not sure. And besides that, drug induced, like in this case, but that's where my differential ends, to be honest.
Beautiful. Promise, I imagine this is new territory for you. I will say that when we say myocarditis, what we're saying is that there's death of the myocardium as a result of autoimmune reaction there. It's basically the cardiac equivalent of interstitial nephritis, where in the cells, in the actual parenchyma of the kidney, there's damage to the kidney cells, and this is the equivalent of that. There are three different big categories of myocarditis before you zoom in. Eosinophilic myocarditis, which is a common complication of invasive parasitic infections or invasive malignancies. And the key question will be, what is this white blood cell? Is there eosinophilia in it? The next type of myocarditis is called giant cell myocarditis. That is an idiopathic myocarditis with a high rate of ventricular arrhythmia and high rate of heart failure. Those two are much less common than the most common cause, which is lymphocytic myocarditis. And that is most commonly idiopathic and unknown, thought to be a virus. But then there are very specific diseases that can induce a lymphocytic myocarditis. The most common and most important infection to entertain is the possibility of diphtheria. Now that's not happening here, but diphtheria causes a horrible myocarditis and a neuritis. There are some other infections that can do it too, but their link with myocarditis is speculative and not actionable, meaning it doesn't matter what the virus is, you can't do much about it, but for diphtheria, you can do much. And then there are autoimmune diseases that can cause myocarditis, and importantly, drugs too. Drugs can do it through eosinophilic myocarditis, like drug-induced hypersensitivity syndrome. But there are a couple of drugs that are two drugs that you should remember as culprits for myocarditis. And that's clozapine, the now very famous antipsychotic medication that is more strongly associated with agranulocytosis, which is why its use is restricted, but it is also strongly linked with a febrile, devastating myocarditis. I remember that because I've actually seen it in a patient. And the other most common cause is immunotherapy, which is, I think, what Mario was hinting at from the very get-go. So here, I think you have to really worry about immunotherapy-related myocarditis, because it's really the only overlap that I think we can see. One big caveat: heart can be diseased from disease elsewhere. And the one thing I'm holding my breath for is to make sure this patient isn't hyperthyroid, because hyperthyroidism can cause fever, tachycardia, and heart failure. So granted, the TSH is normal, I think the case is building for immunotherapy-related myocarditis. I'll pause there and see, Promise, Mario, do you have any questions, anything to layer on before we hear Gabrielle's next aliquot?
I think I feel like I'm obligated to add. We can't forget about the Chagas myocarditis. I think that's one we can't forget. And I think other parasites, helminths. I think you can have is it tricky? No, I think it's one. There's another parasite. I don't remember the name. I have to check it out. But there's a couple of parasites that can cause specifically myocarditis.
You know, Mario, thank you for pausing and adding that. I just realized we actually have 11 minutes. So let's take, since we're confident this is myocarditis, let me just take a minute to walk you through this landscape so that we have full clarity on it, since it seems to be the anchor of the case. So Here we are. Sorry, my screen is not. Remember, 3 big categories. Most of them are idiopathic. Mario, I think what you're alluding to is Loeffler's endocarditis, myocarditis, maybe from many parasites. In the United States, Toxicara is the most common one. We don't have many other invasive parasites in the US except Toxicara, and they hear a couple of autoimmune diseases like Churg-Strauss and drugs, as we mentioned. I think Mario's point is excellent. There's actually a long list of these. We've seen COVID myocarditis, unfortunately. Coxsackie, as Mario said, is the most common. Diphtheria is the most actionable. When I look at this list, of course, these two are important, Rickettsia and Coxiella, but you very rarely are you suspecting them based on myocarditis. You usually have other clues. Toxo is very important, as Kushal just mentioned in the chat, and Chagas too. Very, very important to think about and would probably change your management. So I have to review this and refresh it. I forgot about this cat area. I forgot about this, but I will say if you're practicing outside the United States, I imagine this category is probably the most common. All right, questions, thoughts, ideas? All right, Gabrielle, give us the final aliquot, please.
So for the final aliquot, as the chat was asking, they did a transthoracic echocardiogram that showed a left ventricular ejection fraction of 30% and a global longitudinal strain of 10%. Of 10%, global hypokinesis, and an estimated right ventricular systolic pressure of 40 milligrams of mercury. No significant valvular abnormalities. Also, they did a coronary angiogram to rule out any vascular abnormalities and showed no angiographic evidence of coronary artery disease. And an elevated left ventricular end diastolic pressure of 25. Which was high, being the normal less than 20 milligrams of mercury. So as you guys crashed in the diagnosis, the final diagnosis made was myocarditis induced by or related to an immune checkpoint inhibitor that presenting with heart failure. So just for making some little teaching points, the epidemiology is not well established, but some studies suggest that approximately 1% of patients can develop this at first the condition. And for the pathophysiology, is not well understood, but some studies suggest a shared antigen theory, meaning that the cardiac myocytes and the malignant cells shared a similar T-cell receptor. And this condition can present within 3 months of initiating the immunotherapy. So for the diagnosis, we can do a MRA, which is the gold standard. And I think that's it. Thank you, Chiara, so much for choosing this case.
Incredible. Thank you so much. Maybe we'll open it to Promise to share any reflections, and maybe Promise, if you want to emphasize 1 or 2 things that you took away that you didn't know before that you learned today. I see you taking some notes, so maybe you can share that with us and pass the mic to Mario for him to reflect. And I will say my reflection before I pass the mic to you is it's incredible to learn with you all. And I think for me, this case is a great reminder of some very common things in medicine, but some less common things. And it's great fuel to even though I've spent 8 years now thinking about many of these things, there's still so many gaps in my knowledge. And I'm probably going to spend a little time reading about myocarditis and refreshing on myocarditis and relearning the performance characteristics of S3 versus pericardial knock, etc. And so I hope all of you listening to this are like, oh wow, yeah, like we nailed it and we got it. But like there's the amount of learning and the amount of I don't know will always be more than the amount of I know. And so kudos to you all for being on a very challenging but also very fun journey. You'll never be bored in medicine, ever be bored. Promise, what did you learn and take away?
Well, thank you so much for the case and for everyone's discussion. I feel like this is so helpful for me as I start pathology. And I think like it's funny because today like we're learning about like inflammation and stuff, and I feel like I am already taking away a lot of things. But I feel that I actually have a question. I was just wondering, like, when do we use a chest X-ray and why don't we use a chest X-ray in this case? And then other than that, I think like just reflecting on like in terms of discussing cases, I think it's definitely very humbling to be able to say like, I don't know everything and like, here's the picture and I'm still trying to solve the problem. And there, you know, like you can think of multiple things. And I think one of the biggest takeaway I got from being with, you know, like all these VMRs is kind of like always taking a step back to think like it's really easy to try to want to delve into one route down, but then you always want to like drag your logic and pull yourself a step back and try to see other possibilities and then kind of narrow down with more data and asking more questions. So I think that's something that I take away outside of just the clinical side of medicine.
Beautiful. That is such a great reflection and very inspiring. Thank you, Promise. Mario, where's your head at?
Well, I think the first thing I think I'm gonna keep in mind is what you mentioned at the beginning, Ravi, the test characteristics of the history taking. I think that's something I haven't talked to a patient in a while, but when I was in clinical practice, I noticed that there wasn't that amount of emphasis on the history taking skills. It was just expected that you would develop it by yourself, but I think dedicated practice, I think it's gonna be a very good idea to try to do it in a conscious way. And the second thing, I think I have to also learn a little more about myocarditis and about the TTE. When Gabriel started to mention the pressures, I said, Jesus, please don't make me interpret this because I have no idea what this means. So maybe also check that. But amazing case, and just thank you for the opportunity to keep learning.
Mario, did you notice that I refuse to talk about the echo and the numbers? They have no idea how to interpret it. So that is a gap in my knowledge that I don't even want to plug. It seems so hard and so extreme. So maybe someday I'll be inspired, but I also am running away from the echo. All right, Vale, do you want to take us home with the teaching points, please?
Yeah, sure. Amazing case and discussion. I really had a blast doing the teaching points. So we started with a chief concern, which was dyspnea. And as mentioned, dyspnea usually prioritizes the lung and the heart, and then other causes such as chest wall, neuromuscular, hematologic causes such as anemia, metabolic, such as acidosis, and endocrinopathies such as hyperthyroidism. And then Ravi pointed out key questions that he makes to triage his patients with dyspnea, starting with a time course, in which case an acute onset, we should prioritize more morbid conditions such as an MI or a PE. And then asking for signs of volume overload, thinking about something on the heart, then fever, which prioritizes the lung, and then signs of presyncope, which indicates poor perfusion, something occurring in the vascular lumen, and because of that, we should prioritize the heart if present. And then, as the patient had not only signs of heart failure, but also fever, we were in this kind of predicament of thinking, is this located in the heart or in the lung or in both? And the presence of very specific signs of heart failure, such as orthopnea, but also lower extremity edema and the presence of dyspnea, pointed us to the heart. And even though the patient had fever, this equation of heart signs plus fever make us think of the inflammatory causes affecting the layers of the heart, starting with the pericardium, the endocardium, well, the myocardium, and then the endocardium. And then also the possibility of a pneumonia, maybe progressing to heart failure, thinking that this could be both things, something affecting the lung and the heart at the same time. But also, as a patient had a past medical history of cancer, thinking about a malignant effusion affecting the pericardium. And then also Mario pointed out that the history of immunotherapy in the as part of the cancer treatment of the patient pointed him in risk of myocarditis. And Ravi explained it as that immunotherapy, in comparison to chemotherapy, actually augments the immune system. And so the patient is in risk of autoimmune conditions, or basically the itis of every layer of every organ. And then he shared the cancer plus dyspnea schema, in which we should think about different buckets that compress the lung, the heart, the vascular system, the endocardium, and then other causes such as anemia and acidosis. And also the great pearl is that the most specific sign for heart failure is S3. And as we were coming to the labs, we were asking if this could be pericardial effusion, or we should just start thinking about something affecting the myocardium and just be heart failure. And so Ravi pointed out something that it's kind of associated with physiology and could be interpreted as that, is that when we have pericardial effusion, we really shouldn't expect a predominance of left heart failure signs, because the effusion actually affects the right side of the heart. And so the presence of these signs, such as S3, made it less likely that this could be a pericardial effusion. And also another great pearl was that the VMP is low in pericardial diseases in comparison with heart failure. And so we could use this to differentiate both diagnosis suspicions that we had. And then, as we were thinking about causes of myocarditis, he shared his schema of differential diagnosis, in which most of the causes are idiopathic, but we can differentiate it in 3 buckets: the xenophilic myocarditis, in which we could think about causes such as parasites and malignancies; then giant cell myocarditis, that could present with ventricular arrhythmias; and lymphocytic myocarditis, that we can think about viral causes and diphtheria, toxo, and also Chagas myocarditis. And then autoimmune causes and drugs, in which he pointed out 2 important causes of drugs, clozapine, an antipsychotic, and immunotherapy, like the case of this patient. And then Gabriel shared with us some teaching pearls about immunotherapy-induced myocarditis, that usually it is caused because both the target cells of the therapy and the myocytes share receptors, and so they cause this inflammatory reaction. And it's a very important diagnosis to make early, because the treatment, without treatment, it could be fatal. So thank you so much for attending today, and hope to see you tomorrow.
Absolutely brilliant, Valerie. Thank you so much for that recap. All right, I'll see you tomorrow.